Hello again and welcome to Biotech Atelier 2021. Following is a keynote lecture by Dr. Daniel Dowd, Vice President of Medical Affairs at Genemind, a company of pioneering scientists and leaders in psychiatry, neurology, and genetics, whose common goal is to inform clinicians about genetic biomarkers that influence mental health outcomes. Dr. Dowd, the floor is yours.
Okay, so thanks everyone. My name is Dan Dowd, like Veronica said there. So I am the Senior Vice President of Medical Affairs at Genemind, and I've been there for about 7 years. And as part of this keynote, I thought I would talk a little bit about what I've learned in the field of pharmacogenetics over the last 7 years, and more about the practical implementation of pharmacogenetics and some of the frequently asked questions that we'll hear about, that we have heard about over the last 7 years, and some of the best responses to these questions. So this is me. You're probably less interested in who I am and more interested in what I have to say. So again, Senior Vice President of Medical Affairs at Genemind. I am a pharmacist. I have my PharmD degree, and I manage the Medical Affairs Department. But let's move to the agenda. So like I said, we'll talk a little bit about frequently asked questions, and then what obstacles are there to implementing pharmacogenetic testing. So it's not enough that the science has reached a point where it's generally accepted. We also have to be able to implement this seamlessly into workflow, and then we'll talk a little bit about obstacles and how to overcome them. And then last but not least, we'll talk a little bit about best practices. So we've developed our what we call our golden rules of pharmacogenetics, and we'll close out the presentation with some of these golden rules. So when it comes to frequently asked questions, one of the most common questions is the science valid? So is the science at a place where we can use this in a clinical setting? And in the field of diagnostic testing, we've generally looked at 3 criteria to determine whether a diagnostic genetic test is valid. And the field has adopted those same 3 criteria for pharmacogenetic testing. And the criteria is listed here on your screen. Is the genetic test analytically valid? Is it clinically valid? And is there clinical utility to using the test? So let's talk a little bit more about these 3 criteria, because this question will come up perhaps from colleagues. So analytical validity refers to the accuracy of your laboratory, essentially. So if you get a result that says you are positive for a certain allele, are you actually positive for that allele? So what the lab detected, is that actually the gene or the allele that you have? So it's an assessment of your laboratory. Is your laboratory legitimate? Does it test the right genes? Are the results validated? Is the lab certified? Analytical validity. That is the least of the 3 here. You're least likely to get that question. You are more likely to get the question, are these types of tests clinically valid, and do they have clinical utility? For clinical validity, we're talking about the drug-gene associations and the strength of these drug-gene associations. So if I get a result that says I am a poor metabolizer at 2D6, does that actually have an impact on my ability to metabolize certain drugs? What is the strength of evidence between that genetic result and the actual outcome? Clinical utility has to do with the outcomes associated with this type of testing. So does pharmacogenetic testing improve clinical outcomes? Is it cost effective? Can it be implemented into the system? Clinical utility has to do with the practical aspects of this type of testing. And so for these 3 questions that you may get, here's some answers that we often give and that we have given over the last 7 years. So for analytical validity, if you're thinking about doing pharmacogenetic testing, these are some questions you want to ask about any lab you partner with. So you want to know what they're testing. Are they doing SNP testing? Are they doing whole genome sequencing? Are they doing whole exome sequencing? For pharmacogenetics, most labs are doing SNP testing. So one of the questions you might want to ask is, what is the accuracy of your lab? Have you compared your results to a known standard, and is there concordance between the results? And for SNP testing, it should be greater than 99% concordance. Most of the manufacturers will list that as their accuracy rates. In addition to SNP testing, if we're going to do pharmacogenetics, almost all pharmacogenetic testing companies measure the CYP2D6 gene. And if you're going to measure CYP2D6, you should also be measuring something called copy number variant, also known as CNV. So you want to make sure that any lab you partner with is doing that. Are they assessing copy number variant? Because that will change us from normal metabolizers to ultra rapid metabolizers. And the accuracy for CNV testing is a little lower, but it should still be above 95%. Okay, so these are questions you want to ask to assess analytical validity. Some of the other questions you may want to ask is the lab testing the most relevant genes? We'll get into that more in a minute. And then also, what certifications does the lab have? Here in the US, we need to be CLIA and CAP certified in order to do pharmacogenetic testing, but I imagine that's different globally. In fact, it is different globally. As far as clinical validity goes, are the drug-gene associations real? And there's a wealth of resources that I'll show you in a minute that ranks the level of evidence for these gene-drug associations. And then lastly, clinical utility. Does this improve the health of our patients? And can this be worked into the healthcare system to decrease costs and utility? So going back to analytical validity, digging down a little bit into that, again, you want to ask any partner lab what genes or alleles are being tested, but you also want to make sure that they're testing all the relevant, the minimum number of alleles for things like CYP2D6, CYP2C19, and CYP2C9. So you may ask yourself, what do we mean by the minimum number of alleles? Well, AMP, the Association for Molecular Pathology, has released guidelines for pharmacogenetic testing companies, and they have lists of alleles that you should be testing if you plan on giving results for CYP2D6, CYP2C19, or CYP2C9. Okay, so they've divided these genes into tier 1 and tier 2, and the recommendation is that if you're going to do testing for any one of these genes, at the very least, you should include all tier 1 alleles. Okay, so this is an important question you would want to ask that goes towards the analytical validity of the test. The links provided here take you to the actual AMP guidance. Okay, moving on to clinical validity. Here are 4 fantastic resources to highlight the strength of evidence between some of these gene-drug pairs. Now, our previous speakers touched on this, but it's so important I'll touch on it again. Here in the US, we obviously look towards FDA guidance for any of our gene-drug pairings, and the FDA has published 2 nice tables. One of these tables is called the Table of Pharmacogenetic Associations. Another one is called the Table of Pharmacogenetic Biomarkers. And these are publicly available, and one of the links is here. And if you click on this link, it will bring you to the table, and it will identify all medications that have some type of pharmacogenetic guidance, precaution, warning, black box warning in the actual label. And then the Table of Pharmacogenetic Associations takes that a step further, and it will provide information on drugs that may or may not have guidance in the label, but still have some level of association with a particular gene. Okay. We also look to CPIC. So CPIC, if you're interested in pharmacogenetic testing, become familiar with CPIC. This is an international group of researchers that standardize the field of pharmacogenetics. They publish guidelines. They standardize the conversion from genotype to phenotype. And most legitimate labs will follow the CPIC standardization. I provided a link here to CPIC. You can see all of their guidelines there. You can see how they provide strength of evidence scores for different drug gene pairs. And then very similar to CPIC is an organization called DPWG, the Dutch Pharmacogenetics Working Group. And they also publish recommendations for drug gene pairings, mostly dosage recommendations. Last but not least, PharmGKB. This is an open source site that provides lots of information regarding drug gene pairs. So you can look up pharmacogenetic information based on drug. You can look up information based on gene, and they have their own scoring algorithm to identify how strong a gene and drug association is. So if you have questions about clinical validity, these are the sources right here. PharmGKB is sort of one-stop shopping for all of this because it will branch out to the FDA, to CPIC, and to DPWG. So this answers the question about clinical validity. Clinical utility, I won't spend too much time on this because our previous speaker spoke about these trials also. But when it comes to clinical utility, we want to know, does this testing improve outcomes? In the context of psychiatry, it would be a smart move to look at depression because it's one of the most common psychiatric conditions. And there's been 2 meta-analyses that have looked at depression and whether or not pharmacogenetic testing improves outcomes. I'm going to show you the first one, and then I'll show you the second one, and you'll find that they're remarkably similar. So this first meta-analysis was by Bausman et al. And they found that if you were to compare depressed patients who were tested to those who were not tested, you were about 71% more likely to remit with testing. Okay, so remember that number, 71%. And if you look at this at the other meta-analysis by Rosenblatt et al., you can see that the odds of remission were increased by 74% in this meta-analysis, and this was depressed patients also. But you can see that the odds ratios were remarkably similar. In one study, 71% more likely to remit testing compared to not testing. In another study, 74% more likely to remit. So that certainly speaks to clinical utility as far as outcomes go. In a publication that just came out last month, it was a meta-analysis looking at whether or not pharmacogenetic testing had a significant impact on hospitalizations and drug changes. And the take-home message here is that comparing people who were tested to those who were not tested, you were almost twice as likely to change a medication if there was testing involved, and tested patients were about half as likely to be hospitalized. Okay, and last but not least, we'll talk a little bit about some coverage policies here in the States. So if you're not familiar with Medicare, Medicare is the U.S. federal government's medication coverage for those over 65 years of age. So it's a government-funded healthcare for senior citizens. And recently, Medicare has announced a coverage policy for pharmacogenetic testing. And I just want to highlight the yellow parts right here. So pharmacogenetic tests are indicated for medications that are currently being considered or currently being administered that are known to have gene-drug interactions. And these gene-drug interactions are defined by the FDA label or by CPIC categories A or B. Okay, so if you as a prescriber are considering a drug or have already prescribed a drug, and that drug has a drug gene association that's in the FDA label or has high level of evidence for CPIC, then that's considered covered testing by Medicare. Okay. Now, I fully recognize that the U.S. System is unique across the world, but a lot of government health plans are not currently paying for pharmacogenetic testing, and this can act as a model for reimbursement or payment by other systems. All right, so looking at some of these frequently asked questions, continued, some criticisms that we have heard throughout my 7 years here and how to best respond to them. So often, critics will say there's a lack of data for pharmacogenetic testing. Hopefully, the previous 10 slides I've shown you convince you that there's not a lack of data. Okay, maybe that was true 7 years ago, but that's not true today. Some critics will say there's not enough standardization within the field of pharmacogenetics. Well, CPIC has largely taken it upon themselves to create standards, standard nomenclature, standard genotype to phenotype calls, and most labs have largely accepted this standardization process. Some critics will say that there's a failure to account for ethnicity differences when we're looking at pharmacogenetics. And that's probably still true in some cases. One of the ways we can overcome this criticism is by making sure that when we test certain alleles, that we're testing alleles not just in a Caucasian population, but we're testing alleles that exist frequently in African and Asian populations also. And part of these AMP guidelines recommend alleles that may be infrequent in Caucasians, but happen to be more frequent in those of different ethnicities. So it's probably still a problem in pharmacogenetics, but it's improving every day. Another criticism is that pharmacogenetic testing does not take into account drug-drug interactions, and that's true. That's not the realm of pharmacogenetic testing, but good clinicians and good pharmacists understand this, and they will always take into account drug-drug interactions when they're looking at drug-gene interactions. The nice thing is that there's lots of software, well, maybe not lots, but there is software available that assesses drug-drug and drug-gene interactions. And our company, Genimind, has developed such software. Last but not least, critics will say that there's a lack of education for providers or patients. And I think that is still true. So the burden is on companies like Genimind to make sure they're educating clinicians on the proper way to use this technology. We should be, as clinicians, we should be educating our patients, make sure they understand what pharmacogenetics can and cannot do. And the nice thing is there's a bigger focus on pharmacogenetic education than there has been in the past. Lots of continuing medical education programs are available now. And also most of the testing companies will offer consultations, pharmacogenetic consultations. So that's improving. So let's talk briefly about some of the obstacles to pharmacogenetic testing. The big obstacle is reimbursement. Again, I recognize the U.S. system is different than others, but many agencies are not currently paying for pharmacogenetic testing, and the out-of-pocket costs for individuals can be, out of reach for many people. So reimbursement is an issue. It is improving all the time. I mentioned the Medicare policy that was recently launched. We expect this to have a downstream effect on some private insurers. So this is improving all the time. And in order for reimbursement to improve, in order for more insurers to pay for this type of testing, we will need endorsements from some of these medical consortiums. Workflow integration is critical, especially electronic health record integration. So if this type of information, if genetic information is not part of the EHR, then it will not catch on universally. And one of the things our company is doing is we're working with many different EHR companies, electronic health record companies, to give them the ability to order our test directly from the EHR and then to get results directly in the EHR, both as a PDF file and as discrete data. Then another obstacle is education and awareness, and we talked a little bit about that. So I think I want to end here with our golden rules of pharmacogenetics. So these are our 10 golden rules. If you plan on implementing pharmacogenetic testing, or if you're a clinician that wants to use it, we recommend that you adhere to these rules, and we've developed these over the last 7 years. So number one, a patient's clinical presentation will always win over any pharmacogenetic data. So if a patient's doing great on a medication, but the pharmacogenetic data says there's some type of risk, we're always going to lean on the clinical presentation. Pharmacogenetic data is always probabilistic and not deterministic. And also the data is only one piece of the puzzle in optimizing drug treatments. You should never solely rely on pharmacogenetic data to make any clinical decisions. There are really only 4 pharmacogenetic contraindications. Okay, everything else is just an increased or a decreased risk. The 4 contraindications are related to HLA-A, HLA-B, and in some cases, ultra-rapid metabolizer status at 2D6. But those are the only 4. Our patients and prescribers are partner in pharmacogenetics and should always understand their results. We should always use the published guidelines when they're available. Again, we should always explain to patients the limitations of pharmacogenetics. As with all medical fields, these recommendations will change as the evidence grows, and we've already had to change our test multiple times as new evidence has been published. And then last but not least, if you use pharmacogenetic data, you have an obligation to use it responsibly. Okay, so that's our golden rules. Here's the contact information for me and also Genomind's international sales director. Her name is Dana Schurer. So if you have any clinical questions, feel free to reach out to me. And if you are interested in implementing a pharmacogenetic program, you have Dana's email right here. So thank you everyone for your time.
Thank you, Dr. Dowd, for a great presentation. Unfortunately, we're running a bit late, so there won't be time for a discussion. However, it's our responsibility to forward any questions that the public might have asked and give them an answer later on. Thank you once again.
Okay, thank you.